Good afternoon, everyone, and thank you for joining us as we have a presentation for you this afternoon. We're going to go over monkeypox, MPV, and COVID-19 briefing here. We do have a few guests and just a few reminders before we get started. We have a couple of interpretation options for you that are available. We have an American Sign Language interpreter spotlighted throughout the press conference, and we also have a Spanish interpretation channel available along the edge of your Zoom console. You can use that gray slider bar in the middle of your console to customize your view between the presentation and the presenters. And after this presentation, we will have time for some Q&A. So our guest today, Director Scott Bookman of the Division of Disease Control and Public Health Response at CDPHE, Dr. Rachel Herlihy, our state epidemiologist, and we're happy to be joined by Dr. Connie Saver-Price, the Chief Medical Officer at Deriver Health. So to get things started, I'm going to hand it over to Dr. Herlihy.
Thank you so much. Good afternoon, and thank you all for being here this afternoon. So wanted to start our presentation today with just a quick look at trends that we are seeing nationally. So nationally here in the US, we have seen more than 13,000 cases of monkeypox or MPV. You'll see we're using the acronym MPV today to stand for monkeypox virus. And you'll see that a large number of those cases have been reported on both coasts, New York, California, Florida, Texas, Georgia. Also, Illinois has a large number of cases. You can see on this map that Colorado is also, of course, had a significant number of cases, and we'll go more into Colorado's data in just a second. Next slide, please. So I'm excited to share with you that we are now sharing additional data on our website. That data should be live on our website now. And the type of data that we're going to be updating on a weekly basis on our website, in addition to the daily case counts that we have been updating for many weeks now, include data like you're seeing here, showing an epi curve or an epidemic curve that shows you the overall trend of cases that we're seeing in the state. We've seen so far 168 cases to date. And you'll see that our curve shows that on a daily basis, we've seen through the month of July, a pretty steady increase in the number of cases. And then really since that time, a really pretty consistent number of cases being reported on a daily basis across the state. Always keep in mind, as you've learned with COVID data, that there are lags in data. So important to recognize that numbers from the last few days may always be incomplete. Next slide, please. Right, so I want to talk about some of the specifics about MPV or monkeypox virus. So first, a little bit about how monkeypox virus spreads. So the virus is spread by close contact with monkeypox rash, sores, skin bumps, or scabs from a person with monkeypox, and that is especially during sex. It can be transmitted when symptoms start, all the way until lesions are healed and new skin has formed over those lesions. Currently, based on the data that we are collecting, both here in Colorado and nationally, we are seeing that the greatest risk at this time is among gay, bisexual, or other men who have sex with men. And that is primarily here in Colorado in the Denver metro area, though we have seen cases outside of the metro area as well. Next slide, please. So work that we have ongoing with our local partners and providers to expand access to testing is really an important strategy and effort that we have been undertaking over the last couple of weeks. Thankfully, over the last couple of weeks, there has been much greater access to testing available through commercial laboratories. So commercial laboratories throughout the country are now online and doing this monkeypox testing that was previously only being performed at state laboratories like our CDPHE laboratory. So as I mentioned, commercial lab testing is available and really recommended for patients who have insurance. That can be processed through primary care providers or other healthcare providers. We know that most large systems in the state now are able to collect specimens and do this testing. It does not require pre-approval from CDPHE, and specimens can be collected with materials that many providers have on hand. So things like typical swabs that would be used for something like strep throat. The state lab testing is still available for public health scenarios and for those without insurance. That does require pre-approval, and so we ask that providers reach out to us if they have patients or circumstances where they think testing at the state laboratory might be appropriate. Local partners providing monkeypox testing are listed on our website, so check that out. Next slide, please. So as far as what to do when someone tests positive, so people with monkeypox must isolate at home and stay away from people, pets, and stay home from work until all lesions have healed and new skin forms. So as we've gotten used to with COVID, isolation is important for monkeypox to ensure that additional cases do not occur and that spread of the virus does not occur. Public health will contact individuals that test positive and ask questions about travel, close contacts, and medical visits. This is case investigation, contact tracing type work. Important to note that our interview information is kept confidential, and we are working hard to build trust with individuals and do ask that individuals please answer or return calls from public health so that we can collect that information that we need and also ensure that we can halt the spread and potentially protect other individuals that have been exposed. Contacts are monitored daily for symptoms for 21 days after exposure. But I think also important to note that typical quarantine, like we had done historically for COVID, is not a routine practice for monkeypox. Next slide, please. So we have been working closely with trusted community members to develop the data sharing practices that we are in the data that we are sharing with you today. As I mentioned a few minutes ago, we have updated information now available on our website, and the type of data that you're going to see on our website include some data that are summarized at the state level. And this is going to be summary data on age distribution of cases, data on race and ethnicity of cases, gender, sexual orientation, and then hospital status of cases. Again, that data will all be shared at the state level. Protecting individual privacy is very important to us. And similarly for that, we are going to be showing county level data, but there will be some level of what we call data suppression occurring with that data to protect individual privacy. And so what you're going to see in our county specific data is if there are no cases in a county, that county would be displayed as 0 or not listed. If there are 1 to 3 cases in that county's number of cases would be displayed as less than or equal to 3. And then once we go above that level of 3, so 4 or more cases, that's when the actual count of cases would be displayed. And again, the reason for this approach is to protect individual privacy, especially among some of our smaller counties. When there's case counts of 1 or 2, there is the potential for individuals to be identified. And so protecting privacy and creating trust is important for us. Next slide, please. So the type of data that you're going to see, and these are screenshots of our dashboards, include data like I showed you previously, showing our epi curves, or what those show is really the temporal or the time-based series or case counts that we've seen over time and the overall trend in cases over time. You'll see that the data here is displayed in 2 ways. It's showed here as the number of cases as they are reported by the date they're reported, and then also shown here by the date of illness onset. So 2 different ways to track the data and understand how cases are occurring and the time frame cases are occurring in Colorado. You'll see that there are grayed out areas, again, to account for potential delays in reporting or data completeness. We'll also be sharing data on the number of hospitalizations that have occurred in Colorado, and to date, that has been 6 hospitalizations. Next slide, please. As I mentioned, we will also be sharing data about case counts by county with those data suppression rules that I mentioned. We're sharing data here by race and ethnicity. And you'll see that there is a footnote here that allows you to compare the proportion of cases that we are seeing in each of those racial and ethnic groups to Colorado's population. And so what we're seeing when we look at those comparisons is that similar to the data we experienced and what we saw with COVID-19, we are seeing overrepresentation of cases among some of our BIPOC communities. So we see overrepresentation of our cases in our Hispanic population and also our African American or Black community. Also sharing here data on age group. So you'll see here that we have no cases listed for less than 18. That is because Colorado has not had any pediatric cases to date. Our average age of cases has been right around 35 in the last few weeks. And you can see that the distribution by age group is shown in this table here. And then finally, we also are sharing case data by gender identity and sexual orientation. And one of the things that I want to highlight here is that there is going to be missing data here. Collecting this type of data requires talking to patients to really get the best information possible. And so there are going to be times where that data is missing because it's challenging to reach patients, or for privacy reasons, patients may not be willing to share certain information. Next slide. And I'll hand it over to Director Bookman.
All right. Thank you, Dr. Hurley, and thank you, everybody, for joining us here today. As we scale our response here to monkeypox, we are fortunate that we do have vaccine available from the outset of our response here. And we are hopeful as the federal government makes more and more vaccine supply available across the country, that we will continue to see vaccine coming into the state. It is all controlled by the feds at this point, and then allocated out to states based on population and cases. And so, in our statewide response, we are building our vaccine infrastructure to administer doses today and doses into the future. We have held clinics run by the State Health Department, by CDPHE, but we are also enrolling a number of community partners. These are local public health, community health centers, and many of our large health systems to be vaccine providers. So to date, we have enrolled 59 partners in this effort. We have distributed more than 3,500 doses to those providers. And we are doing a lot of work to partner with community organizations to promote local public health clinics and other standalone community clinics to ensure that those who need this vaccine are aware of it and know how to get it. Next slide, please. And so similar to the data that Dr. Hurley ran you through earlier, we do have a vaccine data dashboard that is available on our website. And you can see that, to date, we have administered more than 4,300 doses to over 4,100 individuals. Next slide, please. I think it's important to realize and to remember that public health is really about a partnership with the public. And so we are doing an enormous amount of work in partnering with our communities to ensure that people know about monkeypox, know how it is spread, understand the resources that are available, so that we can do all that we can to get our arms around this outbreak. So our teams are meeting regularly with organizations that provide services to persons experiencing homelessness, and including harm reduction and other community-based organizations that work with unhoused communities. We also have standing meetings with community partners that provide services to LGBTQ+, sex workers, BIPOC community, to make sure that people have access to testing, have access to treatment, have access to vaccine, and of course doing all of this in partnership with local public health. Next slide. And our community response will really look like partnering with local businesses to host vaccine clinics to reach those who are at the highest risk locations where they already visit. Providing materials so people really can hand information out in an easy manner. And then we have had a large presence at Pride events since June throughout the state of Colorado. And we will continue to ensure that we are bringing information, treatment, and vaccine, meeting people where they are in partnership with our community-based organizations. And I think with that, we go to the next slide. And it's my pleasure to turn it over to Dr. Connie Price, the Chief Medical Officer from Deriver Health. Deriver Health is a critical partner, one of many partners in our response to monkeypox. And so, Dr. Price.
Thank you, Scott, and thank you, Dr. Hurley, and thank you for inviting Deriver Health to this conversation. As you've said, we have an opportunity to come together as a community with a collective public health response. And Deriver Health is one of many sites throughout the state that can provide testing and vaccination. We've seen that since monkeypox arrived back in May, the cases have increased. We've learned more about how it presents and its course of illness, knowing that the presentation can look like a variety of different things. And our capacity for testing and diagnosing this has expanded dramatically throughout the state. So we at Denver Health have appreciated the variability in the appearance of the rash, which can look like pimples, acne, skin bumps, or blisters, and can appear in a variety of locations depending on the site of inoculation. So face, mouth, or other parts of the body like the hands, feet, chest, genitals, or the anus. We advise anyone with a concerning rash to see their healthcare provider to determine if they need testing for monkeypox or another infection. And keep in mind that sometimes people will start their syndrome with a flu-like symptom, and then it will follow by a rash. Some people will get the rash first, followed by other symptoms. Some people will only have a rash. Next slide, please. So we, at our Public Health Institute, we have been a leader in the state in identifying, treating, and vaccinating individuals against monkeypox. And as of yesterday, we have identified over half of the positive cases diagnosed in this state. And so there are vaccines available to people who are 18 years and older, who have had close physical contact with someone who has had monkeypox in the last 14 days. And generally men who have sex with men, whether transgender, non-binary, or gender diverse, age 18 years or older, who've had multiple sexual partners in the last 14 days, or who have had sexual partners that they did not previously know in the last 14 days, or if they've had close physical contact with other people in a venue or where the group was anonymous, they all may qualify for vaccines. And we've given over 492 vaccines at Denver Health to individuals who meet criteria for close contact. And of course, anyone who's been identified by a public health official with a known high-risk contact is somebody who would also be eligible for the vaccine. There's also treatment for smallpox, but its use in monkeypox is not yet approved by the FDA. And so there are experimental or research non-research expanded access available to those who have severe disease or are at risk for severe disease once they are diagnosed. So with that, I'm done with my section. We'll turn it back over to my CDPHE colleagues.
Great, thank you. I think we're going to continue on to a brief update on COVID. All right, so switching gears to a completely different virus, wanted to provide a quick update on what we are seeing for COVID-19 trends. So this figure shows you our case trend in Colorado, a zoomed in view to really just look back several months here. But this nicely illustrates the sustained decline in cases that we've had over the last few weeks. We had a peak in cases in the first or second week of June, and really since that time, overall have seen a pretty steady decline in cases. You'll see that the red line is showing the 7-day moving average of cases. That's a nice way to smooth out the data, and then each of those gray vertical bars shows you daily case counts, but those obviously vary by the day of the week. Next slide. Very similarly, in looking at our percent positivity data, so again, this is the proportion of tests that come back positive of the tests that are performed, and this is based on molecular tests or PCR type testing that is performed. You'll see a nice steady decline in that percent positivity value, now down to 7.6%. Next slide, please. So what we are continuing to see circulate in Colorado now, and this has been the case for the last few weeks, is the BA.5 variant. That is really the same variant that is most common across the US right now. And some of the things that we know about the BA.5 variant is that, you know, as we've seen these Omicron subvariants emerge, they tend to be more easily spread from person to person. We also tend to see a greater degree of immune escape, meaning that individuals that have been previously infected or may have been vaccinated. Their immune system doesn't recognize these new viruses quite as well. And that is, of course, because the virus is doing what viruses tend to do, which is to evolve and sort of ensure that they're going to be able to continue to be transmitted. Next slide, please. All right, so there is some updated guidance that came out very recently from CDC about changes in recommendations. And specifically, CDC has called out that they are no longer recommending quarantine for people who have been exposed to COVID-19, and that is regardless of vaccination status. However, I do want to make sure that folks are aware that they are still urging individuals who have those exposures to take precautions. And so some of the things that individuals should do if they have an exposure is wear a high quality mask in public indoor areas and around other people, stay away from people at high risk for getting sick from COVID-19, postponing travel and avoiding using public transportation if possible. Individuals that are exposed should monitor for symptoms. Those symptoms include fever, cough, shortness of breath. And then we also recommend that individuals who've been exposed get tested, and that timing of that testing is important. So get tested at least 5 full days after your last exposure. If negative, you should continue precautions through day 10. So that means continue wearing that mask, avoiding higher risk settings for full 10 days. And then obviously, if that test comes back positive, that's when it's important to isolate immediately. Next slide, please. So when should you isolate? So if you develop symptoms, our recommendation is to isolate immediately, get tested, and stay home until you know the results of that test. If you test positive, isolate immediately, stay home and separate yourself from others for at least 5 full days after the day you took the test. You may end isolation on day 6 if you never had any symptoms, so you tested positive but without symptoms, or if you have mild symptoms, your symptoms are improving, and you've been fever-free for at least 24 hours without the use of fever-reducing medications like Tylenol or ibuprofen, Motrin, or Advil. So if you stop isolating on day 6, you should also continue the following precautions for 5 more full days. So wearing a high-quality mask around others at home or in public. Do not go places where you are unable to wear a mask. Avoid eating and drinking around other people, and avoid in-person contact with people at higher risk for severe COVID-19. Next slide, please. So people who test positive should ask a healthcare provider about COVID-19 treatment. And this is a really important message that we are really continuing to try and push out. The importance of treatment. We have treatment widely available for COVID-19 now for individuals. And I think we want people to understand that the qualification to receive these treatments is fairly broad now. Not everyone necessarily needs to receive treatment, but many people do qualify for treatment, including older adults or people who have chronic medical conditions. So important to ask your provider about treatment, and also important to ask your provider about treatment early in the course of your infection. We know that treatment's going to work best if it's taken within a few days of getting sick. So important to find treatment fast to lower the risk of severe disease. Some providers offer testing and treatment in an all-in-one experience called Test to Treat. More information is available on our website. Next slide, please. Thank you.
Great. That concludes our presentation this morning. Thank you, Dr. Herlihy, Director Bookman, and Dr. Price. We're going to open it up to the media Q&A portion of this afternoon's press conference. We'll use that raise hand function located along the edge of your Zoom console. We'll start with first questions first. If we have time allowing, we can do some follow-ups or second questions. Please state your name and outlet before asking your question. And anything that we're not able to get to on this call today or during this press conference, please email us at media_info@state.co.us, and we can follow up with you from there. So let's go ahead and get started. John Daly, go ahead.
Hi, John Daly, CPR News. Thanks for taking our questions. As always, we appreciate it. Question about the risk of monkeypox in schools. How do you assess that risk? How does that look? And then also, do we know if monkeypox is airborne? And if so, or if it might be, how does that affect your thinking about what kind of precautionary measures people need to take?
Yeah, I can take those questions. So first, about transmission in schools. So I think important to note in the data that I shared today that we have not seen any pediatric cases here in Colorado, but we are anxiously awaiting guidance from CDC. They have let us know that They expect to release school and child care guidance very soon. And at the same time, we are, of course, talking to partners across the state and encouraging the routine practices that we use now to prevent communicable diseases in schools are practices that really should continue for monkeypox. And as I think you know, we've recently updated our school guidance around COVID-19, and there's lots of good guidance in there about general infection prevention strategies in schools. To your second question, so we don't believe that monkeypox is transmitted in an airborne route, but we do believe that there is perhaps a minor route of transmission through large respiratory droplets. And these respiratory droplets, we do not believe travel far distances. And so this is a very different situation than COVID-19. So with COVID-19, we all know that if you're within 6 feet of someone for a few minutes, there is that potential for the virus to be transmitted from person to person. We believe that those large respiratory droplets associated with monkeypox probably take a much longer exposure period, probably on the scale of hours, to result in the risk of transmission. And so we believe that brief interactions without physical contact, so passing someone at a grocery store, would not be considered a risk for monkeypox transmission. And again, the major route of transmission really continues to be that close physical contact, including contact during sex.
All right, Sarah Flower, go ahead.
Hi, good afternoon. Thanks so much for taking the call. Sarah Flower with KSUT Tribal Radio. Curious, I have a two-parter as well, kind of on the heels of John. I'm curious about college campuses opening up their doors here in the next week or so, and dorm life and what that's going to look like, and what you all are looking at for that route of transmission. And then secondly, I'm also curious about lessons learned from COVID-19 preliminary being underfunded, and local public health across the state and rural areas being overwhelmed. What are we learning from COVID-19, and how are we applying it to monkeypox? Thank you.
Do you want me to take the higher ed? Sure. Okay. Great. So as far as transmission in institutions of higher education, we are having conversations with our partners and stakeholders that work in higher education, so colleges and universities in the state. CDC does have guidance on recommendations around congregate settings. So residence halls would be considered congregate settings. So strategies that can be taken. I think our colleges and universities have learned a lot from the COVID-19 experience over the last couple of years. And so some of the strategies that they've been using, things like having places for students to isolate if they were to test positive, are going to be potentially important strategies again. I would say, though, that we know that colleges and universities are unique environments, and I think there are probably, in trying to understand transmission of a new virus like monkeypox, it is important to understand the social networks and sexual networks, and those are obviously going to be different on college campuses than they are off of college campuses. So I think there's still a lot for us to know about potential for transmission to occur on those types of campuses. But of course, our colleges and universities are preparing for at least the possibility of sporadic cases and looking at infection prevention strategies and public health reporting strategies.
And then Sarah, sorry, Brian, let me jump in on the second question there. We've learned a lot over the last 2.5 years about how to scale a large public health response rapidly. And so I think a lot of that muscle memory has certainly, come right back in our work on monkeypox to date. Obviously, when we talk about COVID and comparing them, they're very different viruses. But we start this response with testing available, treatments available, and vaccines available. And so we are exercising that muscle memory. We are leveraging all of the partnerships that we built over the course of the COVID pandemic and using those tools in our response to monkeypox. And those critical partnerships, whether it is with our large healthcare systems like Deriver Health that Dr. Price represents, all of our local public health agencies across the state, and then healthcare providers who serve all of our communities. And obviously, we are working closely with the community to get the word out. And so, we're using everything we've learned from COVID in this response as well.
All right, let's go to Meg Wingerter.
Hi, thanks for taking the questions. This is Meg from the Denver Post. I wanted to ask about close physical contact as it relates to monkeypox. I mean, obviously you mentioned about sex, but what else would be considered close physical contact? And is there anything people should do other than, look and see if somebody seems to have a lesion before getting close to them? Thank you.
Yes, so when we talk about close physical contact, we're typically talking about skin to skin type contact. And so really there are, I think, lots of different opportunities for close physical contact to occur between individuals. So far, based on the data that we've seen for this specific outbreak, it does look like sex is the primary route of transmission at this point. But we want people to know, obviously, that transmission is possible through other close contact as well. And so, things like hugging individuals if there are wounds that are not covered and there's bare skin contact, kissing, cuddling with other people, those are the types of things that could potentially result in transmission of the virus from person to person.
All right, Barbara Fox, go ahead.
Hey, sorry about that. I'm Barbara Fox. I'm with KRDO News Channel 13. And I was kind of wondering what can rural communities, like places like Pueblo, can kind of like smaller communities, I should say, should expect for the vaccine rollout here, just because as of right now, we didn't have any vaccine availability except for in Denver.
So, we are obviously very limited in our supply based on, the federal allocation of this vaccine. Now, we are hopeful that we will see more coming in the coming weeks and coming months. And so we are prioritizing that vaccine to the places where we are seeing the largest amount of community spread and where the need is the greatest. Right now, that is basically in the Denver metro area. But Dr. Herlihy and her team are evaluating the data every single day, looking at where cases are occurring, and we will move vaccine into every community that needs it as it is available.
Thank you.
Great, let's go to Seth Klayman.
Hi, Seth from the Gazette. Scott, this is probably for you. Is there still a wait list for vaccine right now? If so, how long is it? What's the sort of expected catch-up date? And can you talk a bit more about projections for incoming vaccine doses? How much are we planning to get and how soon? Thanks.
Sure. So our wait list has several thousand people on it at this point, though we do know that people are signing up in multiple places. And so, as we go to schedule people from that wait list, some of them have accessed vaccine in other places. But, we are working our way through that. And again, we are continuing to expand access to providers across the state. In the earliest days, we had one provider, which was us. And then, we added several other providers like Deriver Health. Now we have 59 providers across the state who can give this vaccine. And the federal projections keep growing, to be honest with you. There was another announcement from the White House today that there will be more vaccine available soon. And so, with that combined with moving from the subcutaneous to the intradermal route of administration, we are seeing an increase in supply. And our goal is to continue expanding access through a number of different providers and making sure that those who need this vaccine most for post-exposure prophylaxis have availability.
All right, do we have any other first questions in the room? All right, then we'll go ahead and take a couple of follow-ups. John Daly, back to you.
Great, thank you. Kind of along the lines of the vaccine question, do we have enough tests? How are we doing with the testing supply, for statewide testing and anywhere that folks would need to get tests?
Good question, John. Obviously, our scars from the beginning of the COVID pandemic are still fresh. So at this point, we are not hearing about any issues related to access to testing. We have supplies available. It's a relatively simple test to be done, though it does not lend itself to a lot of the innovations we did with COVID, obviously, with drive-through testing. And we know that we have lab capacity, both at the state lab and at these private labs across the country. And so we really do encourage anyone who has any of the signs, symptoms, risks that Dr. Herlihy and Dr. Price spoke about earlier should see their healthcare provider and get tested.
All right, Meg Winger, over to you.
Hi, just a couple of follow-ups. So now with testing being more widely available, do you think that we have a clear handle on how many cases there are? Because I remember at the beginning, there was a lot of not really having a picture. And the second thing, at what point do you think the state is going to start allowing second doses, or is that not going to be necessary with this intradermal route? Thank you.
I can take that first question. So as far as a handle on the number of cases that are occurring, I think there will always be underreporting of communicable diseases. We know that not everyone will choose to be tested. And there's a variety of reasons why people may not choose to be tested. Of course, we want individuals who believe they have symptoms compatible with monkeypox to seek testing. We know that part of the reason to seek testing is that certain individuals will benefit from treatment. And so our goal there is to really prevent the worst outcomes associated with monkeypox, hospitalization or other severe outcomes associated with the infection. So we believe that testing is important, but I think, as with COVID-19 and other communicable diseases, there's never a complete accounting of cases that are occurring because some people choose not to be tested.
And then as far as second doses go, we're certainly not turning anyone away for second doses today. And with the increased supply from moving from subcutaneous to intradermal, which gives a 5x increase in the total vaccine supply, we are ramping up plans to give second doses to people who have already received their first dose. And that will be our strategy going forward.
All right, I think we got time for one more follow-up. Go ahead, John Daly.
Sorry, with all the questions today. I wonder if, given that folks have been dealing with, 2+ years of COVID, now here comes this other virus that is out there, and we hear about polio in New York, et cetera. What would you say to your average Coloradan about how worried they should be about monkeypox arriving? And we're seeing the case numbers grow, all over the country. They may be exhausted from dealing with COVID after all this time. What would you say is the main message to, the general public?
Well, I'll take that one, or I'll start it, and then Rachel and Scott pipe in. But, I think there's reason for concern for monkeypox because we're seeing an increase in infections. But the reason we're concerned and paying attention is because we have an opportunity that I think was much greater than we had with COVID to actually control it. So that's the reason we're talking to you and the reason we want to get this message out. Monkeypox is not as transmissible as COVID, and it seems unlikely that it would evolve to be that way. It's a very different virus. It's a DNA virus, not an RNA virus, and those do not mutate and change as rapidly. It also takes a lot longer from the time of exposure to develop an infection. And so that allows our public health officials the time to find people to get them the vaccine to prevent the development of infection. And then, the problem with COVID is often that it was transmissible even before symptoms started or that day before. Whereas monkeypox, as far as we can tell, you really do have symptoms. You have to have symptoms in order to be transmissible. And it is with very close contact. So I think for all those reasons, we should be reassured, but not rest on our laurels that because we have that opportunity to get it under control right now. So we got to do it.
Yeah, and I would just add on, John, when we rolled out our COVID roadmap moving forward in February, one of our pillars was, talking about how public health will always be monitoring the situation and always ready to scale our response, and that we would communicate to the public any changes. And so, you can expand that to monkeypox, you can expand that to polio, that your health department at the state level and at the local level continue to monitor all of these situations. We are preparing to respond in any way that we need to, and we are committed to transparent, open communication with the public so they understand their risk and understand the actions that they need to take.
Well, thank you everyone for joining us this afternoon. Thank you, Director Bookman, Dr. Herlihy, and a special thanks to Dr. Price from Deriver Health for joining us here for this call. If there's anything we didn't get to today, please email us at media_info@state.co.us, and we can work with our subject matter experts to get you some information. Otherwise, hope you have a great rest of your afternoon, and thanks again for joining us.